Thank you, Chairperson. I'm very happy to be able to talk about our study in SGA Annual Meeting. And I'm sorry for my poor pronunciation English, and I'll do my best. Thank you. I'd like to talk about our approach to prevent CRC deaths. Firstly, I'd like to show you background. Colorectal cancer is one of the most commonly occurring neoplasms and leading causes of cancer deaths worldwide. The removal of colorectal polyps reduces the risk of CRC deaths. However, patients with polyps constitute a high-risk group for the development of metacolonous colorectal polyps and CRC. Strategy for CRC prevention, it is divided into two parts, primary prevention and secondary prevention. Today, I'd like to talk about primary prevention, especially chemoprevention. What is chemoprevention? This method is intake-specific nutrition or medical products for prevention of cancer. In the cardiovascular disease, chemoprevention of myocardial infarction is very popular. Before discussing chemoprevention, I present you the relationship between lifestyle factors and CRC. This table is referred from World Cancer Research Funds. Red meat, processed meat, and body fatness are convincing risk factors of CRC. Another relation between obesity and cancers and diabetes mellitus have been many reported. To establish the chemoprevention, it will be crucial of the resolution by considering the mechanism. Several large epidemiologic and clinical studies have evaluated the possible preventive effects of more than 200 agents like that. NSAIDs, including aspirin, selective cyclooxygenase 2 inhibitors, have shown most promise for reduction of CRC risk. However, aspirin known to relate GI bleeding and COX-2 inhibitors increases risk of serious cardiovascular events. So it is not established to chemoprevention for CRC until today. Now, we focus on metformin and present our approach to prevent CRC. What is metformin? Metformin is a bigarnite derivative that is widely used for treating diabetic mellitus. 1980s, metformin was discovered and widely used until today. It decreases basal glucose output by suppressing gluconeogenesis and glycogenolysis in the liver and increasing glucose uptake by muscle. Because metformin does not directly stimulate insulin secretion, it is associated with a low risk of hypoglycemia than other oral diabetic agents. Then I talk about present knowledge about metformin and CRC. First, in epidemiological study, patients with type 2 diabetes under treatment with metformin have been reported to be at a low risk of cancer development. This evidence suggests that metformin might be a candidate agent for CRC chemoprevention in diabetic patients. Then we demonstrated the chemopreventive effect of metformin in two rodent models. First, adenomatous polyposis coli, APC mice, genetic colorectal cancer model. This is schema of this study. 9-week-old APC mice were divided into two groups with or without metformin treatment for 10 weeks. The number and size of polyps were analyzed. Administration of metformin significantly reduced the number of intestinal large polyps formation in APCM mice. Next, carcinogen-induced colorectal cancer model represent human sporadic cancer model. 7-week-old mice were intraperitoneally injected with azoxymetin and then treated with or without metformin for 6 weeks for the investigation of HCF formation, or 32 weeks for polyp formation. Treatment with metformin significantly inhibited HCF and polyp formation. Western blot analysis revealed that treatment with metformin stimulated AMPK phosphorylation. Furthermore, phosphorylation of mTOR and S6 kinase proteins was significantly inhibited by the metformin treatment. It is considered that metformin increases chronic epithelial proliferation via the inhibition of the mTOR pathway through the activation of AMPK. Then, we searched for the drugs for the clinical application. We prospectively randomized 26 non-diabetic patients with HCF treatment with metformin or no treatment. HCF is defined as a region containing crypts that are larger in diameter and stain more darkly with methylene blue than normal crypts. These are endoscopic features of HCF. HCF are known to relate with colorectal cancer and considered as a reliable surrogate biomarker of CRC. Magnified colonoscopy determines the number of rectal HCF in each patient at baseline and after 1 month. In the metformin group, the mean number of HCF per patient is significantly decreased. In contrast, there was no significant change in the mean number of HCF per patient in the control group. There is no adverse event in the study period. To short summarize, metformin suggested to have a can-preventive effect in both colorectal cancer model mice. Metformin is safely and directly suppressed HCF formation in humans. Next step, to evaluate the can-preventive effect of metformin against metachronous colorectal adenoma or cancer, we devised a prospective randomized control trial in post-polypectomy patients. This study is multi-center, double-blind, placebo-controlled, randomized control trial to be conducted in non-diabetic patients with a recent history of undergoing colorectal polyps. These results recently accepted Lancet Oncology and will publish soon. This is study 4. All other patients visiting the hospital for polypectomy were recruited for the study. Eligible patients were allocated randomly into either one of two groups, the metformin group and placebo group. Patients in the metformin group received oral metformin at 250 mg per day, and those in placebo group received oral placebo tablet. At the end of 1 year administration of metformin or placebo, colonoscopy was performed to evaluate the polyp formation. A total of 498 subjects were screened for eligibility, and 347 subjects were excluded from the study for the reason like that. The remaining 151 patients underwent randomization. 79 were assigned to the metformin group and 72 to the placebo group. Of these 151 patients, 5 are lost to follow-up, and 13 withdrew their informed consent during the follow-up period. The remaining 133 patients underwent 1-year follow-up colonoscopy. This table shows the baseline characteristics of the subject. There was no diabetic mellitus patient in neither group. Diabetic mellitus is exclusion criteria. In both groups, the number of subjects who had advanced adenoma and multiple adenoma was around 70%. The incidence of total polyps in the metformin group was significantly lower than that in the placebo group. The risk ratio was 0.674. The incidence of adenoma in the metformin group was also significantly lower than that in placebo group. The risk ratio was 0.6. In the metformin group, the number of the polyps and adenoma was significantly lower than in the placebo group. Sorry for busy slide. Then we compared patients with no new lesion, no recurrent, with those with recurrent adenoma or polyps in each group. Age, sex, BMI, and smoking habits was similar for non-recurrent and recurrent patients in both groups. In the placebo group, the proportion of multiple and advanced adenoma in the recurrent groups was significantly higher than that in non-recurrent patients. In the metformin group, the mean HOMA-IR value, HOMA-IR value is marker of insulin resistance in non-recurrent patients after the 1-year treatment was significantly lower than the mean baseline value. The incidence of adverse events was almost 10% and all were grade 1. Difference in the incidence of adverse events was not significantly between two groups. To summarize, low-dose metformin is safe and effective in reducing the prevalence of metachronous adenoma and polyps in non-diabetic patients after pulpectomy. Low-dose metformin may be more effective for subjects who are insulin resistant, even if they are not suffering from diabetic mellitus. This is first randomized control trial to show the effect of metformin for human colorectal metachronous adenoma. These results were suggested the possibility to establish the CRC prevention by metformin. For practical prevention, an agent generally requires the following attributes: low risk of adverse effects, low cost, good drug compliance, evident action mechanism. Metformin meets these criteria. Metformin has been attracting attention all over the world, and now many clinical trials have been going on. This study has some limitations. First, we did not plan to conduct a dose-response study of the effect of metformin on colorectal polyps formation.
2 minutes remaining. 2 minutes.
Second, repeat colonoscopy at 1 year may be too soon to allow reliable detection of difference between the groups. So we are now planning to conduct further large sample long-term metformin prevention trials. Thank you for your attention.